So thank you so much for coming back this afternoon for our afternoon's program. It is my great pleasure to introduce to you Robert Ashford. He is a recovery scientist at the University of the Sciences, and he is a recovery scientist focused on substance use recovery communities, recovery support services and institutions, integrated behavioral health systems, linguistics, I can't even read all this, linguistic patterns and technological interventions for behavioral health disorders. I have had the pleasure to know him off and on for several years now. We first met when we were blindsided and ended up serving on what turned out to be, I don't even know what it was, but it was a marijuana town hall that turned into a very bizarre interaction on the news. So it was a great time. But since then, I've had the good pleasure to know him largely through Twitter, where he is a staunch advocate for recovery and language around addiction. And he's going to be talking to us about promoting recovery with every word, stigma and discrimination. So please give him a warm welcome. Thank you so much.
All right, is my mic on? Can everybody hear me? Perfect. So I'm a little under the weather. So if I sound a little nasally, I assure you I am from Texas, even though I live in Philadelphia and I don't normally sound like this. Definitely belong in the South, but thanks for bearing with me as we get through this together. And thanks for Dr. Potter and all of the team that put this event on. I know it's in the second year, and it's phenomenal to see all of you gathered and hear the conversation this morning. Living in Philadelphia, where we are literally in the epicenter of the overdose and opioid-related crisis, which is much more aptly an addiction crisis. It seems like we have these meetings every week, and I encourage y'all to continue to have them because this is likely still an ongoing effort. We're going to be dealing with this for a long time. So I congratulate you, and thanks again for having me. So a couple different things of what we're going to talk about today. The first is nobody has probably ever heard the term recovery scientist, and what does that actually mean? And it is a real thing. So there's about 3 or 4 years ago, a group of PhD candidates, current PhDs, a lot of work with John Kelly out of MGH and the Recovery Research Institute, got together and said, we're not really studying addiction. We're really focused on the process and phenomenon of recovery, not as an outcome, but as a really holistic process that people with substance use disorders, mental health are going through. So our framework, how we approach the empirical research that we do, centers recovery at everything. So whether it's recovery support institutions and language and stigma and discrimination or bias, collegiate recovery programs, harm reduction organizations, everything is centered from a community-based participatory research approach with people in lived experience. Many of us that consider ourselves recovery scientists, myself included, are in recovery. So it guides everything we do. So that's the framework, but addiction is a serious issue. Addiction scientists are great, but it's not how we approach this. That's our frame of reference is much different. So that's what recovery science is for us. There's a Journal of Recovery Science, also adding some legitimacy to that. It's a real thing, I assure you. So I'd like to get a sense of who's in the room, though. So that's a little bit about me, but I know there's supposed to be a diverse crowd. I know there's law enforcement and treatment providers, so I'm just going to kind of go through a list. If you could raise your hand based on what your primary profession or role or identity is, I'd like to just get a sense of who you are. So who is a treatment provider of some sort? Okay. How about law enforcement? Sort of law enforcement? Gotcha, undercover. We won't talk to you all day, it's okay. What about recovery support providers? So peer coaches, specialists. You're my favorite people in the room. Thanks for all the work you do and everybody else, but a special thanks to y'all. How about other human services or social services? So housing, HUD programs. Okay, cool. What about media, journalists? No, Zach's back here, another one. The two of y'all. And higher education. And primary or otherwise specialty healthcare, so docs, surgeons, etc. All right, so nice. Really, everybody's represented. Anybody I missed? So I have mutual aid, which absolutely I would include as peer recovery supports, but it's how about 12-step programs in the community? Yeah. Okay, military, how about? I didn't mean to slight anyone, I assure you. Concerned citizens, community stakeholders. Okay. How about people in recovery, since I like that one, if you want to out yourself? Cool. So a range of everyone, and what we're going to talk about today, and we're going to start with a kind of a primer on what is recovery, and this is not to insinuate, to tell you what recovery is or isn't, especially for yourself, just as we frame it from an empirical standpoint, what we're looking at. We're going to go into, and most of what we're going to talk about is language or linguistics, bias, discrimination, stigma, stereotypes. We'll look at what the empirical research tells us. This really started as anecdotal. We think this might be stigmatizing. We think it may not be. We don't really know. What about the words we use, the labels we use? Does it matter? We have ample research at this point that essentially says that yes, it matters, and it matters a lot. We'll talk about language and linguistics specific for people in recovery, primarily in 12-step programs where language, certain language is often used, and what that means and how does it come against or be supported by the research. We'll also talk a little bit about imagery, because it's not just language. The pictures we see in the media every day that I'm sure you all see. I know there was somebody here from an affiliate earlier. What imagery do we use in the articles and the videos that we share and the general public sees? Then we'll talk about media guidelines and some for medical professionals. I don't have guidelines. We haven't created some for all the other stakeholders, but you'll get the gist. So we'll start here, a brief primer on recovery. And you don't have to read this chart. It's really not important for what I have to say. The takeaway from this is that in the field, for the last 20 years, there's been about 15 different definitions of recovery that have been published in the peer-reviewed literature. And all that really means is that there is not a single consensus on what recovery is or what it isn't. And it's not particularly important. I'm of the belief as an individual in recovery, for myself, I follow an abstinence-based pathway, but that's personal, very personal to me. But it's not necessarily helpful to me as a researcher or a scientist or a policymaker. So there is a need to define it by some sort of parameters. But by and large in the field, we can't agree. Everything from SAMHSA, who's probably the most well-known and used definition, it's probably the closest and the one that I like, to Hazelden Betty Ford, to the Scots in the UK, just a ton of variance across the board. But there are some similarities, even though there's some differences. Things like quality of life. Sometimes it says things about abstinence, sometimes it doesn't. Sometimes it's about self-direction, individuality. But as I mentioned before, we have a group, a collaborative called the Recovery Science Research Collaborative. And for a frame of reference, this is how we view recovery. This was published in Addiction Research and Theory earlier this year. It actually came out in their last issue. But we look at recovery as an individualized, intentional, dynamic, and relational process involving sustained efforts to improve wellness. And it's intentionally very, very broad. So just like SAMHSA, it includes mental health and substance use disorders as well as co-occurring, and a range of behavioral health disorders that aren't any of those things: disordered eating, sex addiction, gambling addiction, gaming addiction, trauma, you name it. It also has nothing to do with substance use. So there's no prerequisite or premise based on abstinence or sobriety in here, because that's an individualized outcome and goal for some people. We don't want to cut people out unnecessarily that may be helpful in researching both stigma, bias, outcomes, treatment programs, et cetera, harm reduction. So that doesn't mean it doesn't preclude abstinence. It just means that's an individual choice based on a treatment and recovery plan with professionals and the individual. And really it's at the core, because a lot of our work is around stigma and discrimination. It helps to reduce discrimination by not intentionally excluding anyone that might self-identify as in recovery. So if we go back to where we started as a person in recovery, my definition, my identity is very personal. To hear from professionals, policymakers, legislators, researchers, the news, that recovery has some narrow context can exclude me unintentionally, and that can be discriminatory. It's the definition of discrimination. If I'm excluded from policies, and we're going to talk some more about this, based on some kind of parameter, that's not helpful. So we wanted to be as broad as possible to reduce any potential discrimination. And that's really at the core of this movement of all pathways, is really around inclusion. So this was brought up in the earlier, the number, it might have been this table, the 23 million in recovery. We say it a lot. Favor put it out of Oasis's work in the early 2000s. We have updated data though, and it's still really close. So the Recovery Research Institute, John Kelly and his team recently published the National Recovery Study. So what did it say? Why is it important? And why does it even matter if we're talking about language? So this is setting the stage of why language is important. How many people does it impact? And these are just the people that identify and have had in recovery and have resolved an AOD issue. That gets much larger when we start talking family members, loved ones, caregivers, and everybody else that lives are touched by people in recovery or that have resolved an AOD issue. And this doesn't include mental health, which this number would balloon up even much larger. But essentially what they found is it replicated the OASIS numbers within the standard error. 22.35 million Americans have resolved a lifetime AOD issue. That does not mean, and it's important context, 22.35 million Americans do not identify as a person in recovery. Only about half of that number do. It's about 11 million. If you were to ask them, are you a person in recovery? Do you identify this way? They would say yes, that they hold that identity. And that's important context as we build the policies or who we're talking to, what our language says. If we message recovery, but half the population we think we're talking to doesn't resonate with that, it matters. So it sets the stage for this. And most people do naturally remit, because that point was made earlier, and I would say that the National Recovery Study backs that up, as well as the Nezarec data and multiple other population household surveys and epi studies. So where do we go from there? Who's heard of the recovery messaging training or taken it? Well, yeah, a lot of, y'all have anybody else on this side? A couple people at this table? So in the mid-2000s, Faces and Voices of Recovery, it's an awesome organization, it's national, represents through ARCO and others, recovery community organizations, an advocacy group, there's many others, YPR, Facing Addiction, Addiction Policy Forum, et cetera, et cetera. But they started this idea that the way we talk to policymakers in the media matters. Because as people in recovery, people sometimes don't listen to us, or we tell the stories that we might tell in the 12-step rooms or to our peers, others in recovery. They kind of turn a blind eye to that, they get a little bashful, they're not used to our stories. So what would it look like if we did something a little bit different? So they did some focus groups based, what should this message look like? And they came up with the idea that, I'm a person in long-term recovery, and what that means for me is X, Y, and Z. And all of it was based on that and how to talk to media in short 30-second clips, but all of it was meant to be positive reframe of what addiction and recovery looked like. We didn't need to go into front of policymakers in the media and say, I'm a recovering addict, because people they had really negative reactions to that, and that was not going to help us pass policy. So that's where we started. So it was really focused on the advocacy space with media. That was the wonderful logo. If you've ever seen it, that's what it was. We have evolved a little further based on a little bit of research from John Kelly and his team, based on how treatment professionals respond to things like substance abuse. But in 2015, YPR, Young People in Recovery, another national advocacy organization, developed a recovery messaging training, which took it a step further from favor. So it said, not only are we talking to policymakers and media, we're also talking to our family, our friends, school administrators, we're talking to everybody we come into contact with. And if this research that's emerging says the general public does not respond well, they have this bias towards language like addict and substance abuse, maybe we should change it all. Maybe we should only talk in mutual aid meetings in these private settings with the language that we use if we want people to support us. If we want people to know that recovery is possible, if we want recovery to be the centerpiece and the focal message, and that's what it was designed to do. So really the same core content, but just broaden the audience. And that's what that one looked like. We won't spend a lot of time on this, but again, the basics of this whole premise developed by these advocacy groups of people with lived experience was that we need to focus on the solution, we need to be positive. We're going to focus on our recovery story, not our addiction story, knowing your audience, so who you're talking to, and also using positive language, which I referenced before. And the reality is like this or not, it has not been empirically validated, but we do know that tens of thousands of people, of recovery advocates and others, have been trained through it. And that has, at least it's correlated with some movement and changes that are positive over the last couple of years. My favorite actually just passed in Maine. Is anybody from Maine? You're probably all from Texas. Oh, one person. That never works. Sweet. Did you know that this passed? All right, so I'll tell you about it. You'll be excited, I hope. So, and this is something that every state, we're trying to push it in Pennsylvania, where I'm at. We've talked to some of the advocates in Texas, and y'all are in session now to try to get it introduced. But essentially what this bill did was to take the messaging training. This was led by a YPR chapter of young adults in Maine. They went to the legislature and said, we want to pass a bill that says all of the previous passed legislation, as well as any future legislation, and all of your single state authority type agencies and divisions and departments cannot use stigmatizing language in their names, in their copy, anything. So this actually passed, and it is the law of the land in Maine. There is no stigmatizing language in their legislation, in their resolutions, or in their single state authority divisions and departments. Substance abuse is stricken from the record, and so is addict and alcoholic. So this is the impact of that training. So it's, again, while not empirically validated, does it actually promote behavior change? but at least it promotes law change. So there is some positive impact. But despite that positive impact, stigma and discrimination still exist. And I'll ask you this, and you don't have to raise your hand. At no point in time, if we ever do some interaction stuff, you don't have to participate or not. But who has experienced stigma and discrimination in their life? Raise your hand. 75, 80% of the room. This is pervasive, and it's not just addiction stigma and discrimination. And stigma and discrimination are not isolated to one identity. We have these intersections. But most people, and why does that matter? Is stigma and discrimination important? Does it impact people getting help, getting housing, getting jobs? Does it impact their recovery, which is what I'm primarily concerned with? Are people more likely to relapse? Do these things matter? And I think the answer is yes. So what is stigma? If you don't know, or if you think it's just this politically correct term, which I assure you it's not, this is well documented, especially in the social science literature, but it's this idea from Lincoln Felon that based off Goffman's work, that's a label and a stereotype. So in this case, a label in our world may be what? Somebody yell one out. Drunk. Excellent label. What's a stereotype that might come with that? I don't know who said it. I'm looking at you, but lazy. That's fair. Alcohol use disorder was my diagnosis. I would characterize myself that at times, and so did other people. But those are labels and stereotypes. So we're talking about a word. In this case, addict is on the screen. Drunk was the word that was given. But it links a person that's given that label to a set of undesirable characteristics, things like criminal, dirty, untrustworthy, that work to form ultimately a stereotype, which is beliefs, wide-held beliefs or generalizations about a group of people, in this case, that have a substance use disorder. So we don't look at the individual and say, your unique circumstances or characteristics or your past are going to be how we derive an impression of you. We're going to generalize who you are based on this label. So I've never met you anymore, but somebody called you a crack addict. I know exactly what you are. You're a criminal. You're untrustworthy. I don't want you around me. I wouldn't employ you. Please don't marry into my family. All of those things happen at the drop of a dime just with a label. So that's stigma. Discrimination, which is probably more often what we experience, but we don't often call it that. People think it's scary to say that, or it means something more, like we can't call people racist. It's nonsense. Discrimination is what most of our peers, people in recovery, it is what we face every single day. The World Health Organization says substance use disorder is the top 4 stigmatized disease in the world. It's true. But discrimination is it's not just a stereotype or a generalization, it's the actual actions that are taken. Somebody taking those stereotypes, those generalizations, and acting on them because they believe them to be true about a wide swath of people. So what does that look like every day? And I've experienced both of these, so I assure you that both we see it in our research, and since it's my personal experience as a person in recovery, these things happen every day. Denial of housing and employment. We recently had I'll tell you an anecdote, and we have permission to share it, but an RN in recovery went through the 5 years of the professional monitoring program. I'm sure you, EPA? Employment Assistance Program, EAP, there we go. Went through it, had graduated, was finished, applied for a job, got a job offer, went to do his physical. EHR records said that he had a substance use disorder history. Job offer rescinded. Not only is it illegal, but that's the reality, especially in at-will employment states. This is happening to our people every day. People not getting life insurance because they have treatment history on their records, or that they have naloxone prescriptions. This is notorious in Pennsylvania. People getting exorbitant rates because this stuff is tied to them based on stereotypes and generalizations. That's discrimination, bullying and harassment. And it's also a conditioned role of policy disproportionately affecting only certain individuals. We're going to show an example of this, or I'm going to show an example for it. But parity, which isn't largely enforced, but it also, even before the current law, also actively excluded people in addiction or with addiction. So these are labels you've probably all heard of, right? I would imagine that these come down the screen. There's not a single one that you haven't either been called, haven't heard people said, haven't heard on the news, haven't heard in writing or seen in writing. These are common things. Some of these you probably use it. They've been used today in this meeting. They're used often in our records, our medical records. Clean and dirty UAs. These are used pervasively across, and sometimes we just don't think, what do these words actually mean? What do they imply? What do people think about when they hear them? And our country just has a long history of stigmatizing addiction. We're a culture and a society that's based on largely Protestant beliefs. The temperance movements of the 1800s to the war on drugs that's still going on till today. We have this idea that people with substance use disorders, especially severe substance use disorders, are criminals, they experience homelessness, they're sinners, they're unworthy, and they lack self-control. Those are the most prominent stereotypes placed on this group of people. Ideas like they choose this, or you can't trust a junkie. And we won't do this exercise just for the sake of time. When we do this in a smaller group, we ask people, what other conditions or identities or beliefs do you hold and have you placed on others? And either thinking about that, and I ask you now that as you go throughout the day or you leave today, it's going to be uncomfortable to introspect, right? Just think about this. What type of generalizations do you hold? So now we're gonna have a little fun. So we're going to talk about, I think it's fun, maybe y'all may not. We're going to talk about stigma and discrimination. So we're going to go through a couple pictures. I want you to read it and tell me if you think it's stigma or discrimination. The first person can just yell it out when you want to. So let us not forget who we are. Drug abuse is a repudiation of everything America is. Our 40th US President, Ronald Reagan. Stigma or discrimination? All right, 1 for 1. The reason, to hit this point home, and I think it's just important to conceptualize what stigma and discrimination is, this is using a label, so drug abuse, that is associating as un-American. So anybody that's hit with this label, our US president, which goes into millions and millions of homes, if not all of them, especially at this time when this address was given, is saying that drug abusers are not American. Heavy stigma. This is from Ohio. Y'all may, for those of you that are advocates, may remember this. The law enforcement there decided that they were going to post this picture of a couple that experienced an overdose and to publicly put it out there. And the idea was that it would deter others from engaging in this type of behavior. Stigma or discrimination? No. Discrimination. I heard somebody say it. So not only is this a violation of privacy, but you're actively taking action on what will be a pending investigation. And the rationale when they shared this was that they're posting something to make a statement about something that is classified as a medical disease. They would not post this if somebody had epilepsy and had fallen asleep at the wheel, that wasn't under the influence, and that had not relatively recently experienced an overdose. This is singling out a group of people based on a characteristic or a stereotype. And I'm not saying what happened is right. Right or wrong doesn't particularly matter. It's, do you treat with equity anybody in this instance? Are you singling out a group of people? So discrimination. Another one, I'm not going to read these, but these are common headlines. And these are not like from 1990. This is from last year in May. Stigma or discrimination? Good job. Again, using labels to generalize to a broad swath of people that anybody that was given this label is a criminal, dangerous, and violent. That is not true of everybody that has a substance use disorder. Doesn't mean that it isn't true for some, but that's an individual level characteristic, not a population level characteristic. Here's the original Parity Act. It's not the current law of the land, but it's the way this was first written in the 90s. This section shall not apply to substance abuse or chemical dependency benefits. This is the original parity law. Stigma or discrimination? Yep. Isolating in policy form and discriminating against one or group of people. Social media post. This is a thing. So a room full of junkies sitting around shooting heroin. Every time someone dies, another junkie whips out the Narcan. Talking about Narcan parties. Stigma or discrimination? Stigma. Half of you were saying it. So not only is it stigma, Narcan parties are not a real thing. There's not a documented evidence anywhere in the country that it has ever happened. For those of you that have used opioids and been reversed with Narcan, it is not a pleasant experience. You are not doing it and immediately having a party. Like it is stigmatizing and generalizing a group of people that, again, have a disease, that need help. This is not a real thing. Does not happen. And Zach hopefully can talk about it later because he's talked about it a lot. So this is in my wonderful neighborhood in Philadelphia. Kensington, again, the epicenter of the opioid and overdose crisis in large part in the Northeast. So this was somebody running for office. You don't have to read the whole thing, but essentially there was someone likely with an opioid use disorder, at least often used opioids, sitting outside what she assumed was waiting for somebody to get his next, I don't want to say she says drug dealer, so we'll just read that. Is this stigma discrimination? Posting his picture, and the really important part is she's threatening physical violence based on a series of characteristics. Yes. Threatening physical violence against somebody that you don't know, have not interacted with, based on what you think is not only generalizing and discriminatory, but threatening physical violence is not okay. This is the reality, and this is in Philadelphia. We're a very liberal area. It happens everywhere. Nobody's immune from stigma and discrimination. Here's another one, addicted at birth. Disturbing video of baby born addicted to heroin. Born addicted, treating drug-dependent babies. Stigma or discrimination? Are addicted babies a real thing? Stigma, and no, they're not. Babies cannot be born addicted. They can be born dependent. They can have neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. They cannot be born addicted. Addiction means something very specific. It is not dependence. The two are not the same. They're not synonymous. Babies, the idea that babies can have psychosocial or behavioral changes that make them want to seek out substances at born is not possible. It stigmatizes the mothers and it stigmatizes the babies. This is the last one I'm going to give it to you. There was a story not too long ago around a open heart surgeon that performed open heart surgeries that said essentially intravenous drug users did not deserve second chances. Another form of discrimination. For the sake of time, we're going to move forward. I don't know where we're at with time, but perfect. All right, so what does the research say? So at this point, you're just trusting this, maybe not trusting, this guy up front saying language matters, stigma and discrimination are real. What do we know empirically about words that we often use? And this is, as a person prior to becoming a scientist and deciding this was the work I was going to do, was a community-based activist, an advocate for recovery communities. This was the platform we talked about all the time. Language matters. Stop labeling me with these words that we know on some intrinsic level to be stigmatizing. But now we have the empirical proof. So the first one, substance abuse. Abuse versus substance use disorder, so these are the counter term, the more positive one, invoked greater negative explicit bias in treatment professionals. And that was from Kelly and Westroff in 2010. It was the first range of addiction-specific language research and stigma. Our research team at the University of Pennsylvania, Ashford, in 2018, we tested a lot more words. And we not only replicated the finding from Kelly in the general public and in a recovering population, but also found that implicitly, this idea that if you make somebody respond in milliseconds, what is their first impression of a word, substance abuse significantly invoked greater negative associations, both compared to substance use disorder and also in isolation. When people hear this word, they think bad. It's negative. Opioid addict. Same thing. Addict compared to person with an opioid use disorder, negative bias. This was found, it's been replicated twice, first by Kimberly Goodyear from Brown University, and also from our research at Penn last year. Alcoholic, greater negative implicit bias in the general public. And the idea, again, this bias, both implicit or explicit, is that when these words are used, there's a negative association that's immediately generated. Next one, relapse. So there's a variance in this. This is not to say that relapse is negative. We tested these words with hypothesized positive words. Recurrence of use, much more positive in the general public and a recovering population versus relapse. There's all sorts, when we get into some of the qualitative work we've done with people in recovery, relapse implies failure. It's negative, like it has that strength of association. Recurrence of use has none of that baggage with it. So while relapse is not inherently negative, at least amongst the general population, recurrence of use is a better alternative. So we've got some more. So medication-assisted treatment. We've been using this all day today. I hate the word for a variety of reasons. But from our research, it's not that it's negative, but it's that we have a better alternative that the general public and people in recovery understand, and also invokes a more positive bias. So pharmacotherapy, placing substance use disorder or opioid use disorder at the front end of that, or alcohol use disorder if you're talking about naltrexone, invokes more of a positive association, again, general public and people in recovery. Medication-assisted recovery, great word, at least from the empirical research. Not my favorite, again, from the medication-assisted part, but I love anything with recovery in it. But if you use this term, at least from what we know from empirically, can't suggest that you don't. What I can tell you is that medication-assisted recovery and long-term recovery both produce positive bias when tested. Personally, unless somebody wants to identify their pathway of recovery, if it's medication, you're in long-term recovery. I mean, there's no longer a debate. Talk to people, I mean, the thousands of people on medication now, especially in long-term maintenance and in short-term maintenance on withdrawal programs, consider themselves in recovery, and that's good enough for us. It should be good enough for anyone if it's their personal recovery. But empirically, again, positive bias on both sides. And the last one, just like opioid addicts, we take the opioid off and just say addict. Addict versus person with a substance use disorder, more bias, more negative bias. So we also have, and we're not going to go through this whole chart, but so we do a lot of research on this. So this is stuff that we've just recently published. We actually haven't presented on this at all. So as I mentioned before, the kind of work we do, we always go to the recovery community and the community to engage in our research. So we did a series of studies. This first one was a Delphi group, which really just means we're trying to reach consensus among a group of stakeholders. We took 15 people in recovery, 15 family members, both of people in recovery and family members of loss, and then also treatment professionals. And we said, tell us the most negative, stigmatizing words, the top 10 that you can think of, and then also tell us the top 10 positive that you can think of. And these are the words that came out, and there's a lot of similarities, and I think the ones that resonate or should resonate the most is from those that are in recovery, but also the family members. And there's on the people in recovery side, the stigmatizing words, there's not a lot that you probably haven't think about. Some of them that stuck out that we don't often think or associate with stigma in this realm, this field, is sinners, criminals, felon. I think of those, but maybe not. But those are the words that are most stigmatizing to people in recovery, at least amongst this sampling group. Person in long-term recovery, person in recovery, just calling them people. Imagine that. Most positive. If we look at the families, some of the ones that we haven't talked about that I think are interesting, especially for those of you who are family members or work with families, codependent and enabler, number 9 on the most stigmatizing. That's a word that's often used. I mean, there's a debate going on whether or not it's even a real thing. What does it actually mean? But I can tell you, at least from this group, and we've seen this replicated again in some of our studies that have not been published, is family members are stigmatized by that word. It means something negative. So finding a replacement is probably something we need to look at. And then treatment professionals, we see a lot of the same things. Alcoholic, substance abuser, junkie, dope fiend. Person and human being, the most positive, which we thought was interesting there. So we also, it's really important, and this is building up to something to talk about language and recovering groups, and does this matter? Can people still self-label the way they want? But we did a secondary analysis of our large study that had 2,000 people in it, the experimental trial on language and bias, and we wanted to isolate to people in recovery professionals. So do people in recovery have the same type of bias as the general public? Is it higher? Is it the same? Is there interaction effects? What does it matter what type of language, which word we're talking about? And then also health professions. So do health professionals have higher bias? Does it interact with language choice? Does it matter? So we wanted to answer this question, and we chose 2 specific words. So 2 of the more common, substance abuser and addict. And we saw the main effects of language remained across all experiments. So all that research we told you before, it's that same sample. Those all still hold true. Substance abuser and addict were inherently more negative, significantly. But we also saw a main effect for health professionals just with substance abuse. So this meant across the board, the negative associations were dramatically higher, but all associations with substance abuse were higher with health professionals. But that the association with bad was also significant should tell us something about how we talk as health professionals, of what is implicitly invoked when we hear that word that we use all the time in our records, in our talks. We've heard it today, as I already said. And then also interesting for people in recovery, an interaction effect, but only for addict plus bad. So people in recovery, self-identified in the sample, they had stronger negative associations with the word addict than the general public and everyone else, which would seem to fly in the face of what we think about when we think of why those terms are used in 12-step groups and other mutual aid, the form of catharsis, identity. I mean, I've used those labels for myself, but it seems to fly in the face of that there may be some negative impacts to that as well, something we have to continue to explore. And for those of you that like figures, here's the main effect of health professions. On the left-hand side, you'll see D primes, which is essentially a standardized score of implicit bias. You'll see for substance abuse, good. I'm pointing at it with a laser like y'all can see it. Substance abuse good first, substance abuse bad, substance use disorder good, and then substance use disorder bad. Green line is non-health professionals. Blue line is health professionals. There we see the interaction effect for people in recovery. So as the lines intersect for addict plus bad, you see a higher negative association compared to those not in recovery. So what does this all actually mean? So not only from this empirical research, our work, do we know we've quantitatively shown that the associations with language invoke some type of response, both implicitly and explicitly. But what does that mean in the real world and for your practice? Why should you give a shit, about language? I've been trying so good, I told Dr. Potter I wouldn't curse at all today. Why should we care? What does it mean for real people? So the first point is it's a direct barrier to accessing care. With the most recent NISDA reports, previous years, it's always been around 25%, people saying stigma-related reasons are the reasons I do not seek out treatment. Biggest reason is people don't perceive a need. But of those that perceive a need, 25% aren't accessing care for stigma-related reasons, self-reported. This last NISDA that came out jumped up to 39%. Almost 40% of the people not accessing care that perceived a need aren't doing so because of stigma-related reasons. If that's not enough of a reason to care, and the easiest thing we can do, which is language change, that might promote more positive help-seeking behavior, I'm not sure what is. 40% of people almost are not seeking treatment because of stigma-related reasons. We have a problem. We have multiple problems in this country, but that is definitely one of them. We also see, in McGinty's work out of Johns Hopkins and some others, the general public, when we use these words in our policy, in our language, in our media, in our messaging campaigns, our public health campaigns, prevention, love you, but y'all are horrible at this. When we say things like substance abuse and addict and drug abuse, the general public does not want to support policy that has to do with those things, whether it's good policy or not, financially good stewards of the money. I know that's important here in Texas. It doesn't matter. The general public doesn't want to support anything. The public support levels go down when we use stigmatizing language in it. If you want to have a better chance of getting your bill supported, use positive language. It also impacts, and this one is closer to the first, but the quality of healthcare delivery given by medical professionals is impacted by the language used. What that means, there's a study out, if you likely haven't read it, but you can look it up, that there was specifically around sickle cell disease, but in the medical records, when stigmatizing language is used, it transmits to other healthcare professionals, and the quality of care delivered after that is decreased. And one of the meta-analysis is done and systematic reviews on stigma in healthcare professionals. Higher levels of stigma absolutely are associated with lower quality care delivery. So again, this doesn't mean that language is driving all of it. It means it's one of the easiest things we can change, and these are the things it's associated with. Changing language costs no money. There's been a lot of messaging today that what are you most fearful or keeps you up at night? It's all about money, resources. Changing language costs nothing. It's the easiest, most cost-effective thing you can do to make a change today. And most recently, and this is probably the largest impact, especially for me, I've buried over 100 friends since we've been in this mess for the last 2 decades. But in the midst of the opioid crisis, all of these things coalesce, and this can ultimately result in death. Stigma and discrimination is killing people. Whether you like it or believe that or not, it's an empirical fact. We have to do better. On a lighter note, it's never so simple, right? So especially for those of you in recovery that are listening to this, like, whatever, man. Like, I go to a meeting, I'm an addict. I'm an alcoholic. That's absolutely fine. Those are private settings. You should maintain the autonomy to label and call yourself whatever you want. You can even do it in public settings. This is just to tell you, hey, when you do that, there might be some negative repercussions. But if you're in a 12-step meeting or any other mutual aid meeting, you can label and have that autonomy. Nobody wants to take that from you. There's no empirical research that suggests otherwise. In fact, Goffman's work around the spoiled identity says there's a form of catharsis that comes with it. We have emerging research that may be saying there's some dynamic interplay here, that maybe there's some negative outcomes that may be mediated or moderated by that catharsis. We don't know yet, but as of right now, nobody wants to take that from you. Because the right to self-label and identify should always be supported. Even though the research that we have still needs to be done, it's not strong enough yet. So the takeaway here is keep those, continue to do it. Mutual aid meeting and language and self-identification, it's a God-given right. But know that it can be harmful in public settings. So if you were sat here and listened to me talk and you didn't like it, you're like, this politically correct guy from Philly doesn't know what he's talking about, this is ridiculous. Fine, but the takeaway is try to do better in public because people's lives depend on it. And the reason So the recovery community is changing, and this is not a representative sample. It's 40 people. This is the last research that I'll talk about for people that don't like numbers. So we still don't know a great deal about how safe labeling affects those in recovery. It's essentially what I just said. We don't have strong empirical research one way or the other, so the autonomy should win out because people's rights matter. So we have a small sample pilot. This is under review now. We essentially wanted to look at, do people in recovery, stratified by their length and age in recovery, do they use labels in isolation? Do they only use one? Do they call themselves addicts or alcoholics? Or do they just call themselves the person with a substance use disorder? Is that a generational thing or time since resolution or recovery status thing? Or do they use both or neither? So essentially we found people across the spectrum. The ones that use substance use disorder only, very small, n equals 4. The sample was mainly small, but just looking at proportions, people that use addict but not addict only, quite high. Person with substance use disorder in combination with addict, also quite high. Addict only, also quite high. So what we find here is that people change the labels they use. So we're seeing this idea, we call it dynamic label discernment, but depending on context and setting, the recovery community, at least is suggested when the small pilot study that they understand context and setting. And the reason I say this is because we're going to continue to research, does language impact recovery outcomes? If somebody internalizes the label addict, alcoholic, relapse, substance abuser, drug abuser, are they more likely to relapse? Are they less likely to have higher quality of life or recovery capital? We don't know yet. What we do know is that people across the country, this is a sample from 4 different states, can use both labels. It's not hard. People are doing it. So I challenge you to think about context. So when you're in NA or mutual aid meetings, non-12-step mutual aid meetings as well, with family, with friends, with coworkers, speaking in public and on social media, what language do I use about clients? Hopefully you're not talking about your clients, but if you are, if you're talking to family and friends, if you're talking about yourself in any setting, choose the appropriate label. So what does that actually mean? So we created a lot of translational tools to get out there, and these are some of our more recent. This idea of recovery dialects is just that, is that in mutual aid meetings, people in recovery should be able to use whatever labels they want. So the nice stop signs and check marks, because I'm a visual person, this just worked for us, is that in mutual aid meetings, all the green lines are particularly fine. Substance abuser is not in any 12-step literature, so for us, there's no reason to contain that. I mean, you can make the case, but again, it's not part of the programs. Medication-assisted treatment is another one that doesn't make a whole lot of sense for us because there's more positive alternatives. But these are the settings. But if you're part of the general public, if you're with a client, if you're in a medical setting, or you're a journalist, or a law enforcement professional, or a veteran, essentially, if you're not talking about anybody other than yourself, don't use stigmatizing language. There's no reason for it. You have positive alternatives now. And if you didn't have positive alternatives before today, now you do. Language is just the tip of the iceberg, though, especially for the 2 journalists in the room. There's only 2 of you, so. But we also know that imagery can have a similar impact. We know it has a priming effect. We know that it can be emotionally triggering or cues, especially for people that are in recovery or trying to initiate recovery or moderate use. These types of images are everywhere in popular media. They're everywhere on social. The idea that it inspires clicks from editorial staff across this country is sickening, but we know that pictures and video that have this kind of negative content have an effect. We don't know exactly what the magnitude of that effect is or how we can change it. But there's also no reason that a story about the opioid epidemic needs to have pictures like that. It can have a picture of San Antonio downtown skyscape. It doesn't really matter. It doesn't need an ambulance and a rig or pills or anything like that. It doesn't do anything besides clickbait. And we also know, like that last point, that typically if you find stuff in the media, not only do you get the image, you also get the negatives and stigmatizing language, so we think there's probably a synergistic effect there as well. And to close it out, and we'll go to any questions that you might have. The fact is it starts with all of you. Like, we beat this drum. I've been beating it for probably 6 years. And language has changed. I can assure you it's changed outside of NIDA, SAMHSA, and NIAAA, which would take an act of Congress. We've seen organizations change their name. I know she's in here somewhere. And I always say cicada, and I know that's wrong. Cicada, right? Cicada recently changed their name and took out abuse and put in awareness. New York's State Association for Addiction Treatment Professionals did the same last week. We harassed them a little bit on Twitter, not a suggested way to promote behavior change, but their board voted and they did change their name. Casa Columbia, which now just merged with Partnership for Drug-Free Kids, recently changed their name. The Canadian Center on Drug Abuse and Addiction has changed their name. SAMHSA, NIDA, and NIAAA will hopefully get the message and change theirs as well. But a sea change is happening. It's really whether or not, it doesn't matter if you believe in it or not. If you're on Twitter, tweeted this earlier, like science doesn't particularly care if you believe in what empirical research says or not. These things are true. Stigma and discrimination are associated with words. It's time to change. And how can you do that? What's easy? So addict, alcoholic, substance abuser, gone. Don't say them. Person with a substance use disorder, substance misuse, substance use. We don't need to qualify it. We have DSM-5 clinical language. If you need to do a diagnosis, that would be person with a substance use disorder. Addict or substance abuser, gone. Person with an opioid use disorder or a drug use disorder. Alcoholic or substance abuser or an alcohol abuser, gone. Person with an alcohol use disorder, alcohol misuse, alcohol use. Relapse, again, I encourage you, because it has negative connotation, especially in mutual aid settings, and at the individual level, while it's not inherently negative from the research, recurrence of use was more positive. MAT, gone. Pharmacotherapy or opioid agonist treatment is also an acceptable one. I don't know if Alistair's not here anymore, but that's what they use up in MGH. And then also the idea of recovering or recovered addict and alcoholic. You might think that it's a buffer and that it actually is positive because the word's recovery in there. We thought so too. It's not true. Addict and alcoholic overtakes it. So person in recovery is a much better terminology to use. And again, this is speaking to people in general public, non-recovering settings. You're in a mutual aid meeting, private setting, say whatever you want. In public, try to implore these guidelines. And since there's only 2 of you, I won't go over these. If anybody wants these, we use these for all of our events at U Sciences and Penn when we hold a symposium. This goes out to every speaker, every registrant. These are guidelines around not saying substance abuse, addict, alcoholic, recovering any of those things, criminal, felon, convict, homeless, clean, dirty, addicted babies, relapse, MAT. Don't say any of that, and then we give them the positive alternative words. We also ask them to think about stigma and discrimination for the words we use, just to put some thought into it. Saying somebody's homeless, stigmatizing. Saying they're experiencing homelessness is less stigmatizing. For those of you that are healthcare professionals, and I think this is the last slide, healthcare professionals are often the first point of contact across our system. I know you're not a Medicaid expansion state, but this still holds true even here. Sometimes, and maybe it's more true in San Antonio, but law enforcement can be as well, so maybe these guidelines work for y'all too. But you have the chance, as the first point of contact, to really engage someone in the system, and how you have that contact, how you talk about somebody, matters. Since these rates of bias can be higher amongst healthcare professionals, it's important, you need to reflect on this. What do I think about when I hear the word addict, alcoholic, frequent flyer, substance abuser? Do I write those in my notes? What does it make me think about or feel? Do I treat those people differently? Do I wish they would never come in the ER? I think you had made a point earlier talking about that the medical profession has failed, the education system has failed, that nobody wants to treat addicts and alcoholics. It's largely true, even amongst younger medical professionals. But why is that? And what is it? Can we change it? So where to modify that language, because it's not just in your communication with your colleagues, it's your interactions with your patients, with loved ones, with other healthcare professionals, modeling good behavior in the patient's medical record, and then also in marketing materials and internal memos. The amount of content, brochures, and everything else where we see stigmatizing language is abhorrent. It needs to change too, so that's a good indicator. And I will end there, and I think we might have some time for questions. 5 minutes? Is that what you said? 10 minutes. Thanks. So I've never used it before, but I got told we had Slido. So if anybody likes to be anonymous, imagine that. I think we're going to have that up too, or we can pass around a mic. Does anybody have any questions? Yeah. I tried to come over there.
My name is Jim, and I'm a person in long-term recovery in a mutual aid community.
Program. I think you could just be a person in recovery.
So I'm agreeing with a lot of what you said, and I've done some message training, and I believe in it. In my mutual aid, I'm concerned about watering down and softening, because I think there is in the 12-step community, well, let's put it this way, when that first became popular with the Anonymous People movie, I used it in my 12-step meeting, and I got stigmatized. I got discriminated against for using that terminology, as opposed to my name is Jim, I'm an addict or an alcoholic. And the same thing for relapse. I think there's a time and a place for using a very brick word for something that's happened. And okay, so what the question that I'm going to ask is actually to Dr. Potter, the question that I asked of you at lunchtime, which was we've been dancing around 12-step and that community in this discussion all day long. And I asked Dr. Potter, I said, well, when we talk about evidence-based stuff, are we in favor of 12-step? Is that a good thing? And so I wasn't sure of the answer.
So
what did I say?
She said, well,
yeah, what did you say, Dr. Potter?
Well, I'd be curious to hear what you heard.
she said,
Somebody say it.
absolutely, 12-step programs are a great way of encouraging long-term recovery. Did I paraphrase that adequately? Okay.
So
I say that we would do here.
You said that next year I could present That's what I heard you say.
I said one of the. You're welcome. No, I also said it's not something that we don't have groups here, but
Sure.
One of the things that I have always been trained to do and always learned, and I learned at McLean where I was trained, was that we always offer that. And in fact, in most of the evidence-based things that I keep saying, one of the things that our clinicians always do, and I don't know that Dr. King would comment on this, is we always recommend 12-step.
Yeah.
I don't know, Dr. King, if you feel the same way, but we always do.
Mhm. It's already working. So a couple of things there, and I think it's unpacked. Like there's not this philosophical divide. Like when it kind of goes back into privilege conversations, like in general, right? Like uplifting something to have equity with mutual aid programs. And the reason I say that, and I'll say it because I found my recovery through one, is I can say I'm in a mutual aid program and not violate any traditions. And it's a nice way especially for advocates, because I'm not telling you which one, but I can also identify which pathway I belong to. And I think that's important. But besides that, and I know it's a mouthful, is like 12-step is the most prominent and popular recovery support. It's not treatment, but it's the most prominent around the country. And by promoting an evidence-based practice, pharmacotherapy cuts death rates and reduces opioid use better than anything else. By saying that does not take away from mutual aid. They're not, the two are not, or they can be mutually exclusive, or they can be combined. What I think has to be said at the same time is, because the empirical evidence base is solid, 12 steps does work for the people that it works for, and it works for a lot of people. It also doesn't work for a whole lot of others. And I think we can have both of those facts together and also acknowledge that there is inherent stigma and bias for people on medications within 12-step groups. That's an individual group problem because of the way they're organized. But I think we can have those conversations without going each other's throats, which happens across the country. It's not exclusive to San Antonio. And I think it's continuous conversations we need to have, and we can all do better to say, there's evidence based on all sides of this, and we need to have as many options on the table to get people well, including 12-step programs, medication, and alternatives. Other questions? Oh, yeah.
I got it. Just so people can hear.
So one of the things that I've been discovering is there's discrimination within the recovery community itself. And like you were saying, people that are on pharmacotherapy are discriminated from people from 12-step recoveries.
Mm-hmm.
So I came up with a term called recovery discrimination, is now a coined term on Urban Dictionary. And what it says, when someone discriminates against another person in addiction recovery because that person's recovery is not the same. An example, I am in a 12-step program that is the only true recovery, one way, the only way. Methadone is not recovery. And then as an example, this is recovery discrimination because I am on methadone and you don't think I'm in recovery because it's not the same as your recovery.
Mm-hmm.
And so when I do send patients to a 12-step, they get stigmatized.
Absolutely.
And a lot of them don't want to go back.
And that, as a professional, like we need we need to recognize that and tell people. And there should be movements to create things like MARA meetings here, which is, so we see them cropping up, and you may have seen them on social, but it's specific 12-step programming for people that are on medication. But even then, some people don't like 12 steps. So the idea is we have to create infrastructure, especially with all the money we're getting. Not that all community-based resources, but there should be RCOs on every block that hold all recovery meetings. There should be much more education around pharmacotherapy and the realities of stigma and discrimination and the stories people face. Because for every story, there's some on both sides. That some people say, well, no, NA doesn't discriminate against me. That home group may not, but 10 others do. And I think we just have to be honest with our clients as they're going. I think recovery discrimination is great. Love that. What we call it, we took this from some studies in Minnesota with American Indian tribes, this concept of lateral violence. It's the idea that my peer group, those people lateral or horizontal from me, would engage in some type of violence, whether that's bullying or physical violence, because something about me is different than them. And we see there's a ton of lateral violence in the recovery community. And it goes both ways. Like this is not a us versus them. I mean, it goes both ways. We need a lot of healing to take place amongst our community.
Yeah. Hey, I'm Aaron Ferguson. I work for a national pharmacotherapy provider.
You're already getting it. I love you guys.
I didn't realize it until you started citing it, but I actually cited your work in a blog that I wrote for a Life Process program.
Nice.
And I was like, oh, hey, cool. Look at that.
I appreciate it.
So, I mean, despite the fact that I haven't used any heroin in 12 years, I haven't identified as being in recovery for a very long time. So I'm pushing, to kind of change the language as well. I think that's a really good thing. So keep doing that. But one question is that I have for you is, how do you deal with this sort of argument that, okay, well, yeah, we can change the language we use, but the discrimination is still there. So we're just going to find a different word as a placeholder for what we were saying before.
Sure. And so this is, and make no qualms about it, language is only one small piece of all of the work we need to do around social constructions of what's problematic, what isn't, what is penalized and derogatory in this country, because we have a very real concern. It's possible that all of these positive words in 10 years will be as inherently negative as all the rest of them, because language changes over time and stereotypes can be transferred from word to word. The hope I get is, and the answer to your question is that it needs to be a comprehensive and dynamic stigma intervention and really discrimination intervention. We need to change. We need criminal justice reform in this country. It was already said today, so I don't mind saying it now. We need single payer health care because that's the biggest barrier to access outside of stigma for people getting access to treatment. Support it or not, like for our field and our people, that matters. We need public health campaigns that use positive language. So all of those things have to be done concurrently or we're going to be up in the same boat. And I think the one difference we have today that wasn't necessarily around when inebriate asylums became hospitals for drunks or boozers, like language has changed over time, but all of those got negative, is the one thing we have now is we have a vocal recovery community that never existed as it does today, which started in 2001 with Faces and Voices. We have people in recovery that are actively pushing against stereotypes that are associated with stigma and ultimately lead to discrimination. So I think, is it possible that those words will inherently become stigmatized? Yes, absolutely. It probably will to some point. But where we want to get is where we don't have to use any labels at all outside of a medical record. So whether or not you want to identify as a person in recovery or not, like none of that matters. But I think those are some of the differences. But if we only try to change the language and do nothing else, you're absolutely right. It won't matter. Those will become stigmatized labels themselves.
Robert, do you want to did you want to ask your question? You want to pass? Okay.
You sure?
Time for one more. Yeah.
Uh-huh.
His research with the criminal justice system, and there were some like a pilot program on actually changing the language within the system and seeing the positive outcome of individuals that were involved in the criminal justice system when they had a substance use disorder. Have y'all done any more work with that? Because I mean, I'm really interested in see how we can partner with our criminal justice folks here and just support them with some of that training and language change. It's got to be our whole city, all of us that change the language together.
So yes and no. So the bigger question is, especially when we talk about stigma and discrimination, for those of you that are researchers, especially in an academic setting, know this, is federal funding for stigma and discrimination research is virtually non-existent. We've used university funds not just our team, but Johns Hopkins, John Kelly, like we've all had to use discretionary funds because for the most part, NIDA, NIAAA, NIMH does a little better, but they don't want to fund this type of research. So I think we've got to get creative, and whether that's through private or public partnerships or philanthropic and foundations supporting research, which more and more is happening. But it takes money to have interventions and pilot programs like that. That's why we wrote an R21 that got scored but not funded, piloting with 4 treatment centers to essentially, two of them, we were going to change all of their language. The counselors were going to use positive language, and we were going to look at recovery outcomes in that setting to see if they improved or got worse or stayed the same. But it didn't get funded, and it's not the first or the last time that'll probably happen. For some reason, the feds don't like when we use the word stigma or discrimination. SAMHSA doesn't allow the word stigma to be used any longer. So that's a longer story and a different conversation. But so I think people are interested in the work, but it takes a lot of money to do research and do it well. So there's a lot of people that want to, John included and his team at RI, us at the study, and others, I'm sure. So I'd love to talk more about how we can make it happen. We can get really creative on shoestring budgets, but if we want real meaningful research, it's empirically validated and evidence-based to make a stronger case than we can even now, it's going to take a lot of money.
So we need to keep moving. Did you want to answer just that one question, Zach, about the Associated Press?
Whoever asked that, the answer, yeah.
Oh, I forgot about the board.
So I'm a fellow at Northeastern University, and we're creating a sort of movement / organization to get style guides regarding language and addiction to editorial boards and newsrooms. So whoever asked that, feel free to talk to me.
Yeah. And if I might, just because the last one, I
Sure.
forgot about the
And this
board.
is
I'm
it.
sorry.
You're cut
Yeah.
off.
I got the mic. I can do whatever I want. I'm just kidding. You're the boss. So how do you foster an environment where coworkers can be held accountable to not use stigma language? So that would take law, and well, it would take workforce protections. What I can tell you is there's a growing movement out of New Hampshire. We've been doing some work with Twitter and Google and Facebook around recovery-informed workplaces. We have some guidelines that actually modify equal opportunity employment statements and intentionally put in mental health and substance use disorder recovery, as well as leaves of absence to get treatment. So it codifies that language. Doesn't have legal protections, but it is a nice way to do it. So if you had that question, please get into contact with me. I'm happy to send those recovery-informed workplace guidelines that we made for Twitter and Google up, or check out the recovery-informed workplaces in New Hampshire. Their governor launched an initiative. That's a really nice place to start to get our companies, for-profit and otherwise, to acknowledge that they have recovering people working there. Is a good way to get to this place where we hold people accountable. So thank you all.
Thank you. So we're going to have another opportunity with Robert in just a little bit to answer some